Ketamine therapy has become an increasingly popular treatment option for patients experiencing major depression. Now, a new clinical trial out of Stanford has found promise in a sequential treatment with the opioid buprenorphine. Doctors Alan Schatzberg and Jason Ciuccaroni join me now to share more on their findings. Gentlemen, welcome.
Welcome. Thank you for having us.
Thanks for having us.
Thank you very much for joining us today. So can we start? Tell us a little bit about how ketamine works when it comes to treating depression or suicidal thoughts.
Sure. Ketamine is a dissociative anesthetic that's known to be an NMDA receptor antagonist. That's our brain's predominantly excitatory neurotransmitter. And ketamine has been shown time and again to be very effective at reducing depression symptoms and also reducing suicidal ideation. Though some of the work that we've done at Stanford has found that it may in fact also work through our brain's opioid system, our endogenous opioid system. And so there's been findings, of course, that our brain's opioid system could also be used to harness therapies to treat suicide. So a study out of Israel has found that low-dose buprenorphine can reduce suicidality. And so for us, our motivation really was to try to couple this to ketamine so that we could potentially reduce the necessity for repeat ketamine dosings to treat both depression and suicidality.
Give us a little bit more an idea of what your findings are and how this new treatment works.
Well, this Israeli study had shown that buprenorphine was significantly more effective than placebo in reducing suicidal ideation in hospitalized patients, either with borderline personality or major depression. However, the patients at the end of the 4-week trial of using these very low doses still were highly symptomatic in terms of still being suicidal, but they were better than on saline. They were also did not show much antidepressant effect for the buprenorphine.
Okay.
We propose to, in fact, first treat patients with ketamine to give them some antidepressant as well as some anti-suicidal effect, and then 2 days later to repeat the protocol that was done in Israel with very low doses of buprenorphine to see if we could extend and add to the antidepressant effect or the anti-suicide effect. We primarily were focusing on the anti-suicide effect, and the reason for that was in the Israeli study, they showed that the buprenorphine was anti-suicidal, but it wasn't particularly antidepressant.
Right. What implications do you think this has for treating people with suicidal thoughts?
Well, we think that in fact the sequence was highly effective in reducing it in unipolar major depressives. So we think that this could be used for individuals who are suicidal. It could be added to treatment as usual, which we did, which also the Israeli study did. And we think that the drug the drug combination or sequence, if you will, was well tolerated.
It seems to me like the sort of specifics of the study are that, and as you say, the sequencing is very important, and not just in kind of combination, maybe the doses. So how much more work needs to be done, do you think, before this becomes, if you like, in general practice?
Well, what thoughts do you have on it?
Sure. So we found that escalating the dose of buprenorphine at this very low dose, 0.2 to 0.8 each week for 4 weeks, could reduce people's suicidal feelings. So what we really need to see is whether or not those treatments and that treatment approach is durable. So we did follow patients 2 weeks following the treatment course and did notice there was a modest increase in symptoms when we discontinued the therapy.
Right.
So it showed us that basically the therapy worked. Future work that we'll need to do is basically see that if we can prolong the effects, understand for what duration we need to treat this, and also if the dosing is at the right level that we think it is, at the appropriate dose, and also explore perhaps other patient populations with suicidal ideation beyond unipolar depression, such as bipolar depression, individuals with borderline personality disorder, and so that's kind of future works that we'd like to pursue.
Is it possible to wonder whether there are other drugs that can be used in sequence with ketamine to treat other disorders?
Well, there are other drugs that have been tried to extend the effect of ketamine. By and large, they have not worked out very well. There have been multiple drugs, ribosol, lamotrigine, a number of drugs have been tried. There are some actually psychosocial treatments that appear to be effective that have been developed by an investigator, Rebecca Price, at the, which I think are very, very promising. But in terms of drugs, they haven't really been particularly effective. We see this as kind of a unique opportunity. The other thing I think is important is that both drugs are used today, commonly, ketamine and buprenorphine. Buprenorphine at low doses for chronic pain. So they're both available. And so this sequence could be used. And in a population of unipolar major depressives who are suicidal, we have no approved drugs for reducing suicidality. The combination or the sequence we found was highly effective for doing that, but it wasn't particularly uniquely beneficial for reducing the depression. And one of the things that's unique about our study is that we replicate what the Israeli study showed 10 years ago, that the buprenorphine is better than placebo. We've added to the effect by sequencing ketamine before that, but we haven't in fact had a very strong antidepressant effect, very much like the Israeli study.
Well, thank you both very much indeed for joining us. We really appreciate it, and fascinating work, so thank you.
Well, thank you,
Thank you.
for having us.
Thank you.